Good morning. So yesterday we tried to cover, everything in 2 hours. And again, lots of information. Hopefully you're able to get something out of it. Today I have the pleasure of talking with you about one mineral, clinical and research, mostly focused on 25 years of clinical experience. And I promise you I will give you exact doses, times of day, and everything you ever wanted to know about lithium, okay? It'll be both simple and I think, to me right now, lithium is the most fascinating part of my professional career with incredible implications for, I think, both public health and psychiatric treatment. So I guess for those not here yesterday, I'm a consultant for Great Plains and Pure Encapsulations, and I shared yesterday, I think I got fired as a speaker from Shire. I spoke once and told the truth and was never invited back on Vyvanse and binge eating disorder. So I'm back to my roots, which is nutritional and orthomolecular medicine. Every clinical kind of interest in integrative medicine starts from somewhere that we have no training in our medical education or very little training. When I was in school, it's getting better. So my exposure to lithium, again, was from Jonathan Wright. I read a case by him. It was about almost 30 years ago because I was in medical school, I wasn't practicing. And he talked about low-dose lithium. For Jonathan Wright, low-dose lithium is around 20 milligrams. I'll share my clinical thoughts a little bit later. And he discussed a case with someone with a strong family history of substance abuse and using low-dose lithium. Jonathan Wright has been taking 30 milligrams of lithium for the past 30 years. And that's where my interest became, and I will share with you clinical cases. And I've treated thousands of patients with lithium as a pharmaceutical drug and as a nutritional supplement, and that's what I want to share with you today. And I think we have a little extra time, so I'll make sure I leave plenty of time for questions. How many people saw this editorial in the New York Times? Should we all take a bit of lithium? Anybody, or just a few? Well, Dr. Anna Fells, I don't know if anyone knows her, she's a psychiatrist. She went to a conference like this, she heard about lithium, and she wrote a very articulate, well-written editorial in the New York Times. And when I first read it, I said, oh, shucks, there goes my book. Because I was in the middle of writing a book, and we're finishing it in a few months, saying the same thing. And what was truly amazing to me, it was, again, well-written, well-researched article, is the backlash, okay, on the internet. I don't know anybody who read it, from clinicians in the integrative medicine field, from traditional psychiatry, from everybody in the world thought this was like poison. This was going back to Nazi Germany that were doing experiments and comparing it to fluoride or whatever. It was just incredible backlash, and there were very, very few positive reactions to what I thought was one of the best articles I've seen in 20 years. So lithium, I will share with you, has this incredibly powerful negative stigma, as well as the clients we're talking about this weekend, mental illness in general. So we kind of have this double stigma to overcome to begin to understand how to use lithium. You should try to find this. Part of, we set up a website, lowdoselithium.org. It's on the table, but we'll have all these articles, and there are hundreds on lithium. So that's where it all started. I think some of the caution of lithium is warranted, and that's why we're going to discuss it in detail, because some of our brilliant physicians in the 40s were worried about sodium and hypertension, so they had a great idea. Why don't we put lithium chloride in our salt shakers? And so lithium chloride was 2 or 3 companies made lithium chloride salt as a sodium substitute for those with hypertension. And I don't know if it lists how many deaths, but there were a number of deaths related to over-salting one's food with lithium chloride. So it was a scary time. At the same time in Australia, Dr. Cade was experimenting with guinea pigs and lithium, and then with prisoners about its use in bipolar illness. But it kind of set up this very, very strong negative, somewhat frightening experience about using lithium in this country. Lithium was approved, I think it's 10 or 15 years after it was being used as a therapeutic medication in Europe, mainly because of this. When you read these cases in detail, these were very, very sick individuals. They were not healthy individuals using lithium chloride. But indiscriminate use of lithium is toxic, it's dangerous. As many of you know, it's fatal if someone overdoses on lithium. So one of the titles, I kept changing the titles of the book, was Lithium as a Mineral, as a Medicine, and as a Miracle. So let's start talking a little bit about lithium as an element. It's the lightest of all metals. And it was discovered, I think this gentleman was about 25 at the time in the 1800s. So it's really important, the lightest of all elements. And look at the atomic weight, 6.94. We'll come back to that, but remember it. It's distributed in the earth. It's a natural mineral, mainly throughout China, South America. The largest deposits are in Chile and Bolivia. There's some in the United States. I think Tesla, the electric car company, bought the lithium mines in this country because it's critical for their batteries. There are some people that are describing lithium as such an essential trace mineral in the soil that it'll eventually be a commodity like oil. And let's talk about, as a trace mineral, the body can't synthesize. We need to get it from our environment. We don't really know what the required dosages are. Estimates are between 1 and 3 milligrams per day. The average consumption you see is 650 to 3100. The critical part to remember is that lithium varies tremendously in the soil, hence the water supply of where we live in this country, among states, and around the world. So our dependency on lithium varies tremendously. And here's kind of our high-tech foray that lithium is an incredible, valuable mineral in our tech world. The lithium batteries, $3 billion business. Lithium batteries are used in our laptops, in our cell phones, in our electric cars. It's used in airplanes. And I think the neatest thing, it's what we use in our fireworks. If you put lithium under a Bunsen burner, it turns red. So if you see red in the fireworks, that is because lithium is added to the fireworks. Okay, incredibly important trace mineral for technology. Multi-billion-dollar business that many, because of our overconsumption of this mineral, are worried that it might be overmined and prices might continue to kind of escalate as certain countries see this as an incredible financial opportunity. So lithium as a refreshment. Remember our 6.94, right? The atomic weight of lithium. Well, in the early days, in the early 1900s, lithium was used a lot. It was used for the prevention of hangovers, and it was also thought to elevate mood. So 7-Up was based on lithium, right? The 6.94 didn't sound really kind of a marketable number. So 7-Up, and lithium was in 7-Up from the 1920s until 1950. Anybody born before 1950 who drank 7-Up? Okay, so lithium was in our 7-Up. And you see the ads, Fresh Up and Keep Smiling, with a little lithium. So I'm going to focus on what I do for a living, which is a clinician. I'm not a researcher. I don't do research. I read, and some things I understand and some things I don't. But I've been seeing patients for 30 years, and I've been using lithium as a clinician for that time. So I'm going to try to focus a lot of what I say on patients that I've seen in the office and then kind of go back to the literature. But Laura was really one of the more dramatic, and I have a number of cases like Laura. She came from New York City and had a family history of bipolar illness. And the family history was so dramatic with so many suicides, and if not suicides, suicide attempts, that she was one of the early families that were kind of genetically studied in the 1960s by some of the major universities in New York City. So she was put on lithium, and it was a lifesaver for her. She went from a very young woman with a chronic psych illness and out of hospitals to a high-functioning professional on lithium. So what happened? She developed chronic kidney disorder. She returned to Boston, and of course, before I saw her, she pretty much had been in bed, unable to work for 3 years. She had tried other mood stabilizers without much success, and her family brought her to see us. At the time, we did our fancy, metabolic testing, and she had a slight B12 deficiency, so we gave her B12, but everything else was okay. And I did want to share yesterday, I forgot, that many of our bipolar patients have very, very healthy lab tests. Oftentimes they are incredibly healthy with not a lot of nutrient interventions. And that's why the genetics are so powerful and so strong, and lithium can be so helpful. So we started treating Laura. She had, again, kidney disease. She had elevated creatinine. She was seeing a nephrologist. My reading of the literature, I felt lithium orotate was okay. As we monitored her kidney function, she was taking up to 10 milligrams a day of lithium orotate. And over the course of 6 months, she became a different person. She came back to herself, functioning. Her kids were grown. She planned a wedding and was a very high-functioning, healthy person. Somewhere in between that first year, she went back to her nephrologist, who completely flipped out that she was taking low-dose lithium, even though her creatinine and kidney function had not changed over that year that we had been treating her. So she was a very nice woman. She didn't want to upset the nephrologist. I told her the predicament I was in as a consulting psychiatrist. So she told us both that she stopped taking the lithium. Well, she didn't. What she did is that she stopped her for a while and noticed her mood instability. So she started taking back and restarted the lithium and found a dose that was able to maintain her euthymic even mood. And she struggled for so long. For a bipolar patient, it's quite clear what that feels like. And so for her, she found 20 milligrams a week. So it wasn't daily lithium. She had this little, it was like 4 days a week, or however she calculated it. She knew that 20 milligrams, and for many months, I don't know exactly how long, she kept it a secret. Her mood was better. She finally told me, I don't think she's ever told her nephrologist, and I was sworn to secrecy. Excuse me?
What are you doing now?
I think it's such an incredible story that you need to hear it. So she's maintaining this very low dose of lithium, and she's been functioning quite well. This is the dramatic family history, and I'll just share another story that I heard this week. A woman, adolescent, that we admitted to the inpatient unit for depression, and her family history was even more dramatic, where there was 5 completed suicides. And then there are 2 or 3 serious attempts of suicide where one was in a wheelchair, another one, it was just the most horrific family history that I've ever heard for suicide. And this adolescent was been depressed since she was a young girl, middle school, and she had a poor response to lithium. Right? She's tried lithium 300 milligrams 3 times a day, poor response. And so she's someone like Laura that we've started on low-dose lithium, and she tolerates it well. So when we talk about low-dose lithium, we're typically talking about lithium orotate. That's what's sold in both health, nutrition companies. But low-dose lithium also could be lithium citrate, sulfate, or any form of lithium that we can use. I think my experience is the research on lithium orotate is old. It hasn't been repeated. There is some question that it's more bioavailable across the blood-brain barrier, easier, but it's not something that's been studied extensively. In my experience, lithium in any form at low dosages has incredible therapeutic benefits. In the dosages we're talking about, we rarely see any side effects. I'll talk about some of those. And rarely do we detect a blood level. In our patients with kidney disease, occasionally we'll get a very, very low blood level. But the vast majority of individuals, there's no blood level on 5 to 20 milligrams of lithium orotate. So I said I wanted to start off clinically, and I just want to share with you some of the many cases that we've been treating over the years. I think many of you are familiar with the hyperactive, aggressive young kids that cannot stay in preschool, right? How many people have heard the term being kicked out of a preschool? Okay, kicked out of something you're paying a lot of money for, so it's not really the incentive of the preschool director to kick people out, and they work with you, and they cut hours, and they do many things. But Peter was so incredibly aggressive that he was kicked out of preschool. My use of lithium in adolescents and adults is mostly clinical. In young kids, I feel I need a little objective data, and I've been looking at, again, the same trace mineral hair analysis for many, many years, and probably only the past 10 years carefully looking at lithium levels. So if we see here, Peter had no detectable lithium in this hair sample. If we did a lithium sample on everyone in this room, I would say 90% of you would have lithium levels, and a small percentage does not, and that's one of the indicators that we use to treat young children with lithium. When we're treating a 4-year-old, we use liquid and we use micrograms. Okay, so we use 500 micrograms to 1 milligram. Peter, I know well because I'm treating his whole family. He's got other siblings and a mother who's a bipolar 2, and he's been doing incredibly well. And grandmother actually supported us doing some research on lithium because she's been so grateful for the results with her grandchild. 4-year-old aggressive behavior. 8-year-old diagnosed ADHD. We've all seen it. I've spoken to a number of pediatricians in the audience. And there's a subset of kids, 10, 20%, that don't respond to stimulants, right? We've all seen those. Well, Noah was one of those. Very aggressive, classic symptoms of ADHD. The most important part of that overlap of ADHD responding to lithium is, one, the intense aggression and impulsivity. Here, no detectable lithium. Start off typically with that 500 micrograms, and Noel, 8-year-old, was ended up on 2. So 2 full droppers, which would be 2 milligrams of lithium. And this is also really common. This is a woman who was in the Boston area because she was in a residential treatment program. She was from the Midwest, and a pretty severe bipolar illness, aggression, and on multiple medications. And she was tried on lithium, but had a very, very negative side effect profile. She came to see me for nutritional testing. We looked at all of her testing, not a lot there. Again, undetectable lithium. So we added low-dose lithium. She started at 10, well, we started at 5, but she ended up on 10 milligrams of lithium orotate. Complete calming of her mood swings, where she was able to, over the course of the, I don't know how long it was, 6 to 12 months that we worked with her, that she was able to leave the residential and return home. Kept all her other medications, well, we decreased the antipsychotics, but she was on Depakote, but again, not a full response till we added 10 milligrams of lithium orotate. So I just shared, I think those are my, no, let's go, a few more cases. Ready? Patricia, Patty, she was a therapist. She had a family history of alcoholism, and when she was in college, she drank. She's a binge drinker, lots of alcohol. And then she stopped when she's sober for 10 years. She came to see me for depression. We did the nutritional testing. I don't know all the deficiencies that we treated. There weren't many, but we added lithium orotate. One, because of her family history of substance abuse, and this is a quiz question, so family history of substance abuse is one of the major reasons to think about lithium orotate. And so she started on this 10 milligrams, and when I saw her back, and this was within a couple months, she sat in my office, told me that she's feeling better, and then started crying, tearful. And why was she crying? She was crying because she did not realize until she took low-dose lithium how irritable and nasty she had been to her husband and to her adolescent kid, her daughter. Okay, she was, you know, a good mom. She loved her family. She's a therapist, but she had this chronic irritability, this, she described nastiness that she wasn't aware of until the lithium orotate completely calmed her mood. Okay, so family history of substance abuse or bipolar, obviously, and then the symptom that I want to keep coming back to throughout the day is irritability. And we just found out in the child psychiatry literature there's actually research looking at this trait and the genetics of irritability, but that is the most common symptom that we see. A few other cases I just want to share with you is domestic violence, a gentleman, and then my favorite one was I call waiting room rage. So I was 15 minutes late, okay? And this gentleman who came to see me because his stepson had done very well with our treatment, he came to see me and he was enraged. And he spent most of the hour session yelling at me how I don't know how to run a practice. And I found out that he was quite verbally abusive to the office manager. Really, really nasty. And we finally got to why he was here. Well, my wife wanted me to come in because of road rage. Okay, I mean real road rage. Getting out of the car and screaming. He was a professional, he was functioning at work, but had this intense kind of irritability and road rage. And lithium orotate, he was on a SSRI, didn't touch that. Adding lithium to that was the difference. And he's been a huge fan, and he apologized the next time for that waiting room rage. That's the clinical breadth of what we see with a lithium orotate. Let's try to understand a little bit, and we're going to go back and forth and between this concept of low-dose lithium, and I'm going to jump to this concept of pharmaceutical lithium to try to make sense of how we can integrate this into our practices. But let's now focus a little bit on the low-dose lithium. The research has been around for a long time, it's been consistent, and it's been repeated. We talked a little bit about this yesterday. The amount of lithium in our drinking water affects suicide rate, levels of depression, aggression. The early studies looked at homicide and rape. Okay? The first studies in the late 70s, early 80s in Texas. In one part of Texas, very low levels, high incidence of suicide and suicide attempts. The other area, in the drinking water, high levels. And then we repeated this study, 18 municipalities in Japan, and then Austria, And then I think, do we have the, and then we repeated the Texas studies. Okay, and this was not too long ago. I don't have the date on this study, but it was recently. So we have confirmation. The only negative study was done in London, or England, and many people believe that the lithium levels did not vary sufficiently to make any clinical or statistical correlations. So there's something significant about the amount of lithium in the drinking water. I picked this up on a plane about 10 years ago, and it was just a nice cover and very concerning at the time. So lithium, a simple metal, oldest drug in psychiatry, might protect against mental illness, Alzheimer's. One problem, there's no profit in it. And as I look through the literature and we compile the hundreds, if not thousands, of articles, it's just scattered scientists that are trying to look at how they can help individuals and with mental illness and brain disease, but we do not have anybody who's going to provide sufficient funding to do a study on lithium. It's just not the mode of our research, particularly in mental health or mental illness. So this group is the one who's got to take it out to the community. I assume many of you have heard of Bill Walsh. So he's been in the field for many years. He worked with Carl Pfeiffer, and he's been looking at lithium for many, many years. Here's a quote. I was looking at lithium in the 70s and did a controlled study comparing lithium concentration in the scalp hair of convicted murderers compared to well-behaved citizens. The data was striking. The killers had roughly 1/3 the lithium level in the normal range. Reported this to a normal meeting and then the APA, and nobody was interested in the topic. Pretty impressive, pretty profound. So throughout the weekend, you're going to hear many integrative therapies. Lithium, I believe, has to be considered part of the package. How many people are familiar with the term orthomolecular? Oh, wonderful. It's just, it's had just a slow death, and it's really sad because it's just an incredibly powerful term, looking for the right molecules in the brain to improve mental illness, and that might vary by individual to individual. And I think lithium is the kind of perfect example of a orthomolecular intervention for brain health. Okay, so here's the traditional psychiatrist in me, and I know there are a number in the audience, but how many people have prescribed lithium in pharmacological dosages? Wow, okay. So how many people understand that it can be incredibly helpful? Okay. And then I won't ask the question, but I actually don't prescribe it anymore in pharmacological doses, even though, as I'm sharing with you, I think it is a miracle drug because of the potential side effects. But let's talk about that miracle pharmaceutical research that is really somewhat neglected by our colleagues. This is lithium and suicide. It is the only anti-suicide medication that's been ever shown, or actually Clozaril has some anti-suicide effects as well. But here we have one of the early studies, 1997, academic study looking at patients ill with bipolar illness for over 8 years, 300 patients. On the lithium, suicide rates decreased 7 times. Okay? They stopped the lithium, increased 14 times. And then first year off lithium, suicide rate rose 20 times. It's pretty dramatic, pharmaceutical and lithium. And then here's, in terms of a meta-analysis on depression, not just bipolar illness, 30 to 50 times increased risk of suicide for those with mood disorders, unipolar or bipolar, and pretty dramatic overall risk of suicide decreased 89% lower with lithium. Dramatic. And then here's 48 randomized studies, over 6,000 patients, lithium more effective in, obviously, than placebo in decreasing suicide. The research is quite clear. Pharmacological uses of lithium has dramatic effects on suicide prevention. And when we use pharmacological doses, we use anywhere from 900 to 1,800 milligrams. And on low doses, doses that, quote, many psychiatrists tolerate, we get things like hand tremors and thirst, frequent urination, nausea, vomiting, and some drowsiness. Before I forget, I just want to make sure for anybody, most of these kind of common side effects are completely resolved by taking essential fatty acids. Combination of omega-3 and omega-6, it resolves the tremor, the thirst, some of these kind of nagging side effects. Sometimes we need high doses, 3 grams for a little bit. But the higher dose side effects are both serious and irreversible. The kidney damage is irreversible. The thyroid damage is irreversible. And it's very hard for me to know what I know to prescribe these high doses of lithium. Now, I certainly would do it for a manic patient in the short term, 1 to 3 months, whatever we need to stabilize mood. But it's very hard for me to write those now, and I haven't done it for years, to write those monthly prescriptions for 1,500 or 1,800 milligrams of lithium. Why? Because many times we can get the same therapeutic effect with the low-dose lithium. Go ahead. So the dosage makes it either a remedy or a poison. So let's talk about the food sources of lithium. Well, it's not in animal products. It's mostly in vegetable products. Mushrooms, kelp, sardines, pistachios, and tomatoes, and thyme, the herb thyme. I have not proven that. I read it, and then I read it again, but I have not, I don't have the source. But I said this at a suicide prevention conference, and a gentleman from the Middle East came up and said that on their table, well, first of all, he told me in his country, and I forget which, that there's, low rate of suicide. He was a psychiatrist. But he said on their table, they put the olive oil and thyme, and it just sits, all day long that people dip bread in it. So he liked the fact that thyme had high source of lithium. But it's in our food sources in very small amounts, but most of the lithium that we get is in our water supply. So I don't know if Dr. Shah had said this, but I'm going to steal it if he hasn't, because it was in his slides when I looked at them. But I think it's coming up. He said, is our water too clean? Okay? And we have to begin to realize, because I shared with you, I've been looking at the same hair test since 1990. Okay? And the dramatic undetectable lithium has increased in the past 10 years. So we have food sources. I think someone told me beets. But we have food sources, but water is the biggest supply of low-dose lithium. So now I kind of want to jump to what I think is the most exciting, certainly for me, over 50, and for the kind of destructive implications that dementia and Alzheimer's is playing, for many individuals. So the literature is becoming quite clear of lithium's neuroprotective and neuroregenerative effects. And dementia affects almost 36 million people worldwide. It's increasing dramatically, threefold increase by 2050, 115 million individuals. And again, some of the science is quite complicated, but many of us learned very early on, and every layperson knows about the plaques and tangles, right? Beta amyloid and the neurofibrillary tangles. So how can we understand that? Well, if you read the literature, and on the website we have hundreds of articles, that it is quite striking that lithium has an effect on both the prevention of plaques and tangles. And let's try to understand it. First of all, we have this neuroprotective effect that we've known for many, many years. If we put lithium in a test tube and we put this toxin and we watch the destruction of cells, if we did it before, and then we add lithium, we have decreased destruction of cells in the test tube. And then if we go to our animal studies and we take these poor rats and we cause some anoxia and brain damage, if we give lithium before, we have, here in this study, decreased brain damage by 50%. And then we also can do the same studies to these poor rats, and if we give lithium 1 to 2 days later, we significantly decrease brain damage. And then we have lots of other models of neurotoxins in the brain where we add a little lithium in the test tube or in our animal studies, and lithium has this incredible both neuroprotective, and then if you look under the electron microscope, kind of neuroregenerative properties. The dendrites grow, the neurons expand. It's really cool when you look at the pictures. I don't know if this quite does it, but it's really cool. Okay, let's keep going. So how did we begin to start looking at lithium for the prevention of Alzheimer's disease? Well, the first studies were in trying to understand patients with bipolar illness. So this first study looked at 66 patients with bipolar and a 5% Alzheimer's disease diagnosed, 5% with lithium and 33% with those not on lithium. So one of the earliest studies that kind of had people thinking. And then, like many, I call it research of the absurd. I think most of us are kind of reading the newspaper now and understanding the Alzheimer's research is pretty simple in terms of understanding the onsets are now 30 to 40 years before symptoms, right? We've heard that, that's fact, that's common knowledge now. This is not something we developed. So this was one study looking at low-dose lithium for 10 weeks. Okay, so they gave lithium for 10 weeks and they can say that there's no effect on dementia and Alzheimer's disease. But there were some better studies, and there are many out there. They're kind of all over the place in terms of dosing and controls, but I'm just going to share some of them with you. Here was British Journal of Psychiatry, 45 subjects with mild cognitive impairment, not dementia. And here it was not the lithium orotate, it was low-dose lithium, 150 to 600 milligrams. Compared to placebo. And here, long-term treatment was associated with lower overall concentrations of the tau proteins, okay, as well as improvement in treatment-reduced cognitive decline compared to placebo. Okay. Here, very tiny doses, 0.3 milligrams. Again, 15 months, a little better than 10 weeks. Lithium patients, stable cognitive performance. So a lot of our dementia, Alzheimer's work is just looking for stopping the progression. I mean, that's huge in itself. I mean, we have $1 billion pharmaceutical industry, and I can't believe the use of many of these Alzheimer's drugs and very little effect. But stopping the progression is what people get excited about. Here we had stable performance scores throughout the study. 3 months into the study, patients started showing improvement in the mini mental status exam. Here, this was a chart review of 1,400 patients. There were no improvements in memory or dementia of those who were currently taking lithium. But then they looked back, and then those who had taken lithium in the past, a history of lithium, there was significant improvement in memory in that subset. So it appears that the chronic administration over lithium over time is what can induce some of these neurochemical changes. So there are lots of biochemical factors that how lithium works, and I'm just going to share with a few of them. And the question that I just need you to kind of ask yourself and read about is, can lithium reduce some of these modulating biochemical factors? And I'm going to talk about a few over breakfast. I realize I didn't mention others. I wrote down, but there are many more. Let's just talk about a couple of them and try to understand them. So there's an enzyme called GSK3. So don't make me pronounce it, please, if we can just stick with GSK3. But it's this incredibly important enzyme. And what it does, it kind of phosphorylates certain amino acids. Don't ask me which. Serine was one of them, okay? And it's incredibly important for brain development, okay? But what happens in Alzheimer's, you have this kind of exacerbation. You have too much GSK3, okay? So we kind of hyperphosphorylate certain proteins. And guess what? It's the beta amyloid and tau. So GSK causes the production of these tau proteins that cause the tangles and the beta amyloid that cause the plaques. So lithium inhibits this enzyme. It's called the direct reversal inhibition. So we have Alzheimer's, we have this enzyme that's kind of going crazy, and lithium can say, whoa, and it puts the brakes on GSK3. It's been studied for 20 years. There's one article that I read that said something like, coming out of the closet after 20 years of research. Okay? It's a critically important enzyme that we need it for brain development. It speeds up out of control in Alzheimer's. Lithium, very well studied, puts the brakes on GSK3. Okay? It creates these abnormal proteins. It's very simple. How about IMP? Well, when we have these abnormal proteins in our cell, we have this wonderful kind of, house cleaning mechanism, right? We kind of break down and destroy these abnormal proteins. And that's called, I can't pronounce it well, but autophagy, right? So we break down these abnormal proteins in the cell, and we're cleaning house. Well, what happens is this enzyme IMP is actually the recycling factory in the cell. So that shuts down the breakdown, and it keeps recycling these abnormal proteins. So lithium comes in and inhibits IMP, so it shuts down the recycling factory, and we can start the process of destroying some of these abnormal proteins. Okay? And then everybody has a favorite, well, I don't know if everybody, but I have a favorite nutrient, which is lithium, and my favorite peptide is BDNF. How many people? Brain-derived neurotrophic factor. It's this incredibly wonderful thing, and no matter what you read anywhere, if someone feels better, the BDNF is high. If someone doesn't feel well, it's low. The pharmaceutical literature, the nutritional literature, the animal literature, it's this incredible peptide. Okay? So we want BDNF to be increased. And what increases BDNF? Zinc. There's research looking at probiotics, mindfulness, lots of things help us increase BDNF. Even antidepressants increase BDNF. There are things that lower BDNF, all the things we don't want, which is primarily inflammation and stress. But lithium has many mechanisms where it increases the genetics synthesis, the synthesis of BDNF. It turns on the genes to help make BDNF. Okay? Here's my little increased dendritic growth. BDNF. And then we have studies. This was done in 2009, a blind placebo-controlled trial, lithium on agent, and here demonstrated that healthy BDNF serum levels compared to placebo with cognitive performance supporting the increased BDNF. We've heard glutathione, right? We've had, there'll be talks on it. So lithium, without going into the mechanism, lithium enhances glutathione synthesis. This was a study that got some press a number of years ago. Lithium was found to actually take one of the omega-3s, DHA, and kind of make it into this super anti-inflammatory molecule, the 17-hydroxy-DHA. So lithium creates this incredible super anti-inflammatory agent in the brain with the omega-3. Okay, before I get going, let me just write my breakfast thoughts, which I didn't mention. I just wanted to throw out. Lithium increases serotonin, right? Increases serotonin in 3 ways: presynaptically, postsynaptically, and preventing the reuptake, so serotonin stays in the synapse longer. Lithium increases MAO, monoamine oxidase, okay, which was found to be low in aggressive conduct disorder kids. And then lithium decreases glutamate. We'll talk a little bit about, but I wanted to make sure I mentioned, we talked a little bit yesterday about B12 levels and folate levels being high in the serum. And guess what? Lithium supports the transport of B12 and folate across the blood-brain barrier. Lithium supports the transfer of B12 and folate into cells and across the blood-brain barrier. So incredible amount of information that's sometimes overwhelming, but I just wanted to give you the big picture that we have clinical and we have research, and we need to connect the dots. And here's the last in terms of the prevention of dementia. 45 individuals a couple years ago, low dose, 1 to 2 milligrams, double blind, 12 months. And here they were able to show there were decrease of the tau proteins. This neuroprotective, neuroregenerative kinds of properties are looked at now in many other illnesses. I don't know if you've seen, there's research looking at Parkinson's now with lithium. There's research on ALS, Huntington's. The ALS, there were a couple positive studies, and then there was one large negative study that came out recently. Parkinson's seems to be promising. Huntington's is just beginning. Again, it's just a smattering of research around the globe. Not much is done in the States. And again, I believe it's probably the profit incentives to do this research. But I think one of the simpler models that we can begin to think of, just, and there's studies, was this there were women, cancer studies in breast cancer, but there's a neurocognitive deficit that many individuals that receive radiation and chemotherapy have. Have you heard this? For sometimes years. And there are a number of studies now, number meaning 2, that I've read that looked at lithium in preventing and helping reverse some of the cognitive effects. So let's go quickly. So the punchline for me is going to be, how can one mineral have such a profound effect on human health and neurochemistry? And I believe, as we started yesterday, it all comes back to genetics and epigenetics. So here, lithium has been shown for a number of years to downregulate the NMDA receptor. So that's how it decreases glutamate, and glutamate is destructive. But here, we see that lithium affects over 50 genes. Okay? It supports the transcription and synthesis of many, many genes essential for brain function, and the serotonin transporter gene is one. So why are we concerned? One, we want our patients to feel better, and the bipolar gene does not appear to be going away. Many of us think it's increasing, and many of us think, and don't quote me, but I think some of the SSRIs might be triggering some of these epigenetic phenomena, because some of these kids, have not had family histories, and they're certainly presenting with bipolar symptoms even once they've been off the SSRI. But early use of SSRIs is a concern. And suicide, I talked about yesterday, is my major concern. I mean, it's just so mind-boggling. By 2020, the rate of death from suicide will increase to 1 every 20 seconds. And the literature on lithium and suicide prevention is indisputable by any academic standards. And we know the epigenetics of suicide. So this is a wonderful study looking at post-mortem studies. and showing there were different genes around for methylation in those suicide completers. So the Big Bang produced helium, deuterium, and a small amount of lithium. Unfortunately, it didn't generate enough last element for our politicians. Lithium, which is kind of really fascinating, was one of the first 3 elements in the universe. And that's true, and that's kind of mind-blowing. So I brought up this yesterday. I don't believe in God, but I believe in lithium. It's a painful story. This woman's life changed, and she had to stop her lithium, and this just came out probably a month ago, and I wanted to rush and send her an article on low-dose lithium because, she's worried about, she had to stop lithium, worried about kidney transplant, and it's unclear where her mood is going. So this is the book we're finishing up, Preserving Memory and Optimal Brain Health. And then what I wanted to show you is lowdoselithium.org, the website, where we've collected all these articles for you to look at and have it make sense for you. And as you see, we're going to talk about ADHD, substance abuse, dementia, anger, and all the wonderful things. So similar to yesterday, lithium is one tool in the toolbox that we can use, has profound implications for the prevention of mental illness and for the treatment of those with mood disorders, substance abuse disorders, and that core symptom that's hard to identify in a research model, but certainly you and I understand it as that irritability and sense of anger that one can't control. And if we can look, for those causes, and we can use those orthomolecular interventions, we actually can use words like curing mental illness. So I'll stop and we'll have time for questions.
Thank you so much for your presentation. I have